everyone. I think we're going to make a start. My name's Melanie Abbott. I'm a reader in global mental health here at the IOP, and it's just fabulous to see how many of you have come on a warm Thursday afternoon, and I know you could be in the park, but you really want to be here hearing the great speakers we've got lined up for you. So what we're going to do is kick off with the first speaker I'm going to introduce, and I'm going to introduce each speaker as we go. They've really got a maximum of 20 minutes, if you don't mind, yeah. And we're going to just take a couple of questions after each speaker and then have time at the end. And as you know, afterwards, you're very welcome to join us for drinks. Particular thanks to Rosie for putting the whole seminar together and for arranging today. So it's a huge pleasure to start by introducing Prof. Crick Lund, who's visiting us from University of Cape Town. I've been fortunate to know Crick for some years and to work with him on at least one project, two actually, yeah. So Crick Lund is Professor and Director of the Alan Fisher Centre for Public Mental Health at the University of Cape Town. And he's got so many projects under his belt, it would be difficult for me to name them all, but the ones that you'll have particularly heard of, the PRIME project, which is a DFID funded research consortium standing for Programme for Improving Mental Health Care, and also the AFFIRM project, which is a research capacity building hub. But Crick has always been an absolute leading light in the area of work on poverty, so we're really delighted that you could be here. Okay, over to you, Crick. And he also surfs at weekends.
Yeah. It's always low tide in London, unfortunately. So. All right, thank you very much, Melanie. Good afternoon, everyone. Thank you very much for the opportunity to speak to you today. Let me just try and get the talk up. So, I've been working for a while in this whole area of trying to understand more about the relationship between poverty and mental health in low and middle income countries, and been presented within the last year or so with a really nice opportunity to look at some longitudinal data from South Africa, the National Income Dynamics Study. And I've been working with a statistician, Maelenn, who's a PhD student in the School of Public Health with me at UCT. It's my first foray into the complex, bewildering field of structural equation modeling, so if you have any complex statistical questions to ask, I'm sure Anibali will be happy to answer them, but I'll give it a go as well. Alright, so this is really about reconsidering social drift, and I'll say a bit more about the context behind that title as I go along. It's very much preliminary data. We haven't published it yet, so we'd be very interested to hear thoughts on this, and we're hoping to submit it within the next couple of months. And the outline is fairly straightforward: background, methods, results, and discussion. So just by way of background, I think many of you are aware there's been increasing recognition over the last 5 years or so of the importance of the relationship between poverty and mental health in low and middle income countries. As part of the WHO Commission on Social Determinants of Health, they published this report called Equity, Social Determinants and Public Health Programs in 2010, and it's included a chapter on mental health, on the social determinants of depression and ADHD. And in the same year, the WHO published this report, the Mental Health and Development Report, which I think makes quite a compelling case for targeting people with mental disorders as a vulnerable population who require development assistance. And also in that year, the UN General Assembly Declaration on Global Health and Foreign Policy cited this report and spoke about mental health problems as having huge social and economic costs. So I think within the broad discourse around poverty and development, mental health is gaining increasing prominence. I'm sure many of you are aware of Miranda and Vikram Patel's, G. Miranda and Vikram Patel's well-known article on the links between mental health and the Millennium Development Goals. Sarah Skeen also published this very nice article in the International Review of Psychiatry in 2010, which explored the relationships between the MDGs and mental health, focusing particularly on poverty, education, child mortality, maternal health, HIV and the environment. And I think, again, made quite a compelling case for many of the links between the MDGs, presenting the argument that many of the MDGs really can't be fully addressed without including mental health. And I think, I'm hoping many of you will be aware, if you're not already, please do have a look at the website for Fundamental SDG, which is a campaign that Graham Thornycroft is leading to try and get mental health included on the SDG targets, again picking up on this theme. We published a systematic review in 2010 in Social Science and Medicine titled Poverty and Common Mental Disorders in Low and Middle Income Countries. And of the 76 community-based studies we found, there was an overwhelming majority which showed a statistically significant positive association between increased risk for common mental disorders and various domains of poverty. So in terms of this epidemiological literature, there's quite a clear association. If you are poor, vulnerable, have less resources at your disposal, you have greater risk for a range of common mental disorders. And in this review, we defined CMD as anxiety, depression, or somatoform disorders. And it was really quite striking. It was true across age ranges, across rural and urban areas. Poverty was associated with increased prevalence, with increased severity, longer course, and worse outcome. The trouble with this data is that the vast majority of these studies are cross-sectional. So around 85% of the studies in our review, only about 10% were cohort studies, and only around 5% were case control. So this makes it very difficult to say much about the causal relationship between poverty and common mental disorders. Do conditions of depression or anxiety increase risk for people to drift into poverty during their lives? Or is it the circumstances of poverty that lead to increased risk for common mental disorders? So we've tried to understand this in terms of a cyclical relationship. And the one causal pathway which explains the relationship between poverty and mental illness is sometimes referred to as the social causation pathway. So circumstances of poverty, which might include economic deprivation, indebtedness, low education, unemployment, all those things that you see on the left there, increase the risk for mental illness through high levels of social exclusion, high levels of stress, the daily grind, worrying about whether you have enough food or money for your children, worrying about whether you'll be able to support your children to complete their education, income insecurity, reduced access to social capital and a safety net, malnutrition, obstetric risks, and violence and trauma all explain increased prevalence of mental illness, poor care and lack of care, and a more severe course of the illness. But the relationship also moves in the other direction. So as a result of living with a mental illness, you're more likely during your life to drift into poverty because you spend more on your health care, including your mental health care. And that could be out-of-pocket payments for traditional healers, or it could be direct out-of-pocket payments for private or public health services. You're more likely to lose employment, and you're more likely to be less productive, partly as a result of stigma, which is associated with your condition. So there's been a lot of debate about this, and one of the defining papers was written by Bruce Dorenvent and colleagues in 1992, published in Science, and based on an Israeli study, made quite a compelling argument that the social causation pathway better describes the relationship between poverty and depression, but the social selection, or sometimes referred to as the social drift pathway, better describes the relationship between poverty and schizophrenia. This is a really interesting area. It's very well summarized also in this paper by Benedetto Saraceno and colleagues, published in World Psychiatry in 2005, if any of you are interested in this. But it does raise a number of concerns in my mind, and one of these is, does this lead to a discounting of the importance of social drift or social selection in the relationship between poverty and depression? And conversely, does it lead to a discounting of the social determinants of schizophrenia, or the social causation pathway in schizophrenia? And then secondly, can we perhaps try to quantify the relative contribution of social causation and social drift? Can we say more about which is more important for which conditions in this poverty mental health relationship in low and middle income countries? And so that's what really led us to this paper. we're interested mainly in these questions. First of all, what is the longitudinal relationship between depression and poverty in South Africa? Secondly, does the social causation or social drift pathway best explain this association that we see between poverty and depression? And thirdly, what is the role of depression severity in economic outcomes? So if you have more severe depression, are you more likely to drift into poverty during the course of your life? So let me just describe this data set to you. It's really a great opportunity. It's the National Income Dynamics Study is something that's led by Murray Leibrand and Ingrid Woolard from the South African Labour and Development Research Unit at UCT, where I'm based. And it's really the first nationally representative longitudinal household study in South Africa. It collects data on individual, household and neighbourhood levels, and it provides quite detailed socioeconomic data, including income, assets, employment, education, and quite remarkably depression. No mental health people on their team, but someone thought to put the CSD-10 in their data set, which is just fantastic. So it really provides a great opportunity. It's an open data set if any of you are interested in looking at it. And currently the first three waves from 2008, 2010 and 2012 are available for scrutiny. So this is a bit of what the sampling involved. There was a two-stage cluster sample design, including almost 7,300 households across 400 primary sampling units. And these follow the same sampling units as the national census in South Africa. And this is stratified by district councils, 53 districts in South Africa. Wave 1 had just over 28,000 participants. Not a great response rate at household level, but once households agreed to participate, 93% of those individuals participated, which is not bad. There was quite an uneven response rate across racial groups, which I'll talk more about in a moment. And then there was not great attrition, around 19% between Wave 1 and Wave 2, and around 16% between Wave 2 and 3. And trained field workers conducted interviews, collected anthropometric data. And then for the purpose of our analysis, we had data on around 11,400 adults aged 15 years and over at Wave 1, who were then successfully contacted in subsequent waves, and we have data on them which includes the Centre for Epidemiological Studies Depression Scale. And then the SALRU team also introduced calibrated weights to adjust for the initial response bias and some of the attrition between waves. Okay, so when we start to explore and try and understand the relationship between poverty and mental health, we immediately run into all sorts of complex conundrums around how we define and measure poverty. I saw in The Guardian yesterday there's a big controversy because the Tories now want to redefine child poverty in the UK. We have similar debates in South Africa. We adopted the asset index approach, which has been adopted by the World Bank in around 300 demographic and health surveys in 90 countries. And basically it takes individual and household socioeconomic status as a latent construct whose observed indicators are a set of assets or household characteristics or resources. So it's basically the resources that an individual or a household has at their disposal. Quite interesting to adopt this approach in the light of some of the work that Carol Anna Schenzel has done in the Los Angeles Depression Scale, where she showed, I think quite convincingly, that the reason people live with depression are at increased risk of being in lower income groups is that they both have increased life events, but they have less resources to deal with the consequences of those life events. So she makes I think quite a convincing argument for the importance of resources or assets as a kind of buffer against life stresses, against life events, which help to protect people from slipping into depression and despair. So this asset index, we think, avoids some of the problems associated with using income. Part of the problem in South Africa, as in many low and middle income countries, is there's a highly unequal distribution of resources. So especially among low-income groups, the distribution is highly skewed. Also, many South African households in informal settings won't have a formal income, And thirdly, people are often reluctant to disclose their income. So there's some issues with assets, which I can talk about a bit later. One of the questions that immediately arises is, do we think something as solid as assets that exists within a household would be responsive to mood, depression within a household? But that's something I'll talk to in a moment. So basically this approach uses a factor analysis. So we conduct a factor analysis of a large number of different categorical variables which represent household assets and characteristics. And then the first factor in this factor analysis is taken as a latent construct, which is a representation of household socioeconomic status. And any indicator who's loading on this factor of household socioeconomic status or individual socioeconomic status that was less than 50 or 0.50 was excluded. So we ended up with 23 indicators in our household socioeconomic status construct, and these are the long list. In the interest of time, I'm not going to go through all of them. Notice that some of them are negatively correlated, but this basically tots up to a continuous variable from 0 to 23. And for individual socioeconomic status, we included 10 indicators, which you can see here: radio, stereo, sewing machine, and so on. And we also tested the stability of this measure across waves, and I'll speak a bit more about fit in a moment. Then in relation to depression, we didn't really have much of a choice. We were given this Center for Epidemiological Studies depression scale, the 10-item version. I'm not sure how many of you are familiar with this, but the original instrument was a 20-item instrument. Apparently the 10-item version doesn't lose a lot of the psychometric properties of the 20-item version. It's slightly tricky because 2 of the items are reversed, and there's some evidence that among low education populations that introduces difficulties in the reliability of the instrument. But it basically covers the major components of depressive symptomatology. Again, I'd be interested to hear questions or comments from you about cross-cultural validity of measuring depression. We've done some qualitative work in the AFFIRM study in Khayelitsha and found that although many of the terms people use to describe their experiences of depression differ, many of the core symptoms are quite common to those identified in the ICD-10 and the DSM-4 and 5. So basically it asks about depressed mood, feelings of guilt and worthlessness, feelings of helplessness and hopelessness, psychomotor retardation and sleep disturbance. And you score the instrument from 0 to 30, with the highest score meaning more severe depressive symptomatology. So these are the questions. I was bothered by things that usually don't bother me. I had trouble keeping my mind on what I was doing. I felt depressed. I felt that everything I did was an effort, and so on. This scoring, my apologies, is not quite correct. These should be all zeros. This should be 1s, 2s, and 3s. Yeah? So you get a score from 0 to 30. And it's asking about experiences during the past week. So then the analysis we did was really structural equation modeling, as I mentioned, and we used these latent constructs of socioeconomic status, as I've described, and depression, and tried to look at using linear regression coefficients to estimate the relationship between these constructs over time. And this was using something which I've learned a whole lot about recently called cross-lag models, which is basically trying to assess the causal effect of individual or household socioeconomic status on depression, and then conversely the causal effect of depression on individual or household socioeconomic status. And as I mentioned, we use standardized regression coefficients which allow us to look at the strength of the relationship in both directions and to compare these. Okay, I've got 5 minutes, so I'll whiz on. And this is really an attempt to visually depict this. So if we have our latent construct of depression being made up of a number of individual items from the CSD-10, and the latent construct of household socioeconomic status being made up as well of a number of individual indicators. we can test the relationship between depression in time 1 and depression at time 2, but also depression at time 1 and household socioeconomic status at time 2, and conversely, household socioeconomic status and depression. These are the 3 waves that I mentioned, 2008, 2010, and 2012. So here are some of our results. These are just some of the characteristics of the sample. As I mentioned, just over 11,400 individuals, age 15 and over. Around 39% were men. And you can see the age distribution here, mainly a younger population, consistent with what you might expect in a middle-income country like South Africa. This is the racial breakdown and the education, with the majority of people completing secondary school. These are the indices of model fit. So again, this is something I'm learning about as I go, but this variable here, the root mean square error of approximation, looks at the extent to which the data fits the hypothesized model, and the hypothesized models being socioeconomic status at the household level and at the individual level. And generally, a level of less than 0.06 is thought to be acceptable. So we had numbers of about 0.001, which is quite good. Similarly for this comparative fit index. And these are our sort of headline findings. So what is interesting at the household level is that we see pretty much what Bruce Dorenbent and colleagues hypothesized. We see mainly a social causation pathway. So the dotted lines show non-significant relationships, and these are linear regression coefficients with 95% confidence intervals, and the bold type is statistically significant. So you can see there's a non-statistically significant relationship between depression and household socioeconomic status. So depression at time 1 doesn't lead to worse household socioeconomic status at time 2. And the same was true for the relationship between time 2 and time 3. But, and this is where it really, I think, gets quite interesting, when we look at individual socioeconomic status, we see evidence of both social causation and social drift. So we see here that while there is a significant relationship between individual socioeconomic status at time 1 and depression at time 2, the converse is also true. So people who have higher rates of depression are more likely to have worse socioeconomic status at time 2. And the same was true for the relationship between time 2 and time 3. Interestingly, because we're using standardized linear regression coefficients, we can actually compare the strength of these associations. And you can see the strength of the association for the social causation pathway is twice that of the social drift. So it's still predominantly a social causation pattern, but there's still some evidence of social drift. Again, interestingly, when we looked at breakdown by gender, there wasn't much difference between men and women at the household level, but at the individual level, this relationship of both social drift and social causation was evident for women, but not for men, which is what you might expect, as we know that the prevalence of depression in women is about twice that of men in South Africa. And then this is where I thought it got quite interesting. So I said to Anibale, can we break the data down and look at the depression scores by severity? So are more severely depressed people more likely to show more social drift? And bingo, we found something which is, I think, quite interesting. So this is a full sample, and you can see it's quite narrow confidence intervals because it's the full sample, and this is everybody. When we take the subgroup of people who scored 10 or above on the CESD-10, it's more or less the same. But as we go down with more severe depression, we see quite a clear relationship, and this is at the household level, that as you have more severe depression, you have a more pronounced effect of your depression on household socioeconomic status. Unfortunately, because the numbers get quite small, the 95% confidence intervals get quite wide. But I still think this is quite interesting. And the same is true for individual socioeconomic status. So we can see depression actually has quite a powerful economic effect at a national level And I'm going to just finish off. So the main finding is that household poverty in each wave is positively and significantly correlated with depression in the following wave. But the reverse is not true. That is, depression doesn't predict household poverty in the following waves, which is kind of what we'd expect. But at the individual level, there seems to be some evidence that both social causation and social drift are operating. And I think this makes quite a compelling case, again, for addressing mental health as a social and economic development issue, as we've been saying, in relation to the MDGs and the Sustainable Development Goals. That unless we think about mental health at a population level, we're not going to address a whole lot of these mental health related factors which actually do have a profound impact on individuals' socioeconomic status. And the impact is found, interestingly, more for women than for men. So if we're thinking again at a population level about targeted interventions, we'd want to be thinking about targeted interventions for women that can help address negative cycles of depression and poverty. So this really, I think, offers support for the hypothesis that the effect of depression on poverty is more evident among people with more severe depression. And I think I've said that already. And this has a bearing on other work that we've done on the relationship between poverty and mental disorders. We published this paper in The Lancet as part of the second Lancet series on global mental health in 2011. This was a review of interventions to try and break the cycle of poverty and mental health. And we found, in the case of the first review, which is shown in red at the top here, that poverty alleviation interventions which try to address the social causation pathway, for example through conditional cash transfers and unconditional cash transfers, loans, asset promotion and so on, had really quite a mixed effect. There were some studies which showed, for example in Mexico, the Oportunidades program, that there was an impact on depression, but others showed no effect. Whereas, and I think this is one of the sort of take-home messages from this paper, the second review, which looked at the economic impact of mental health interventions, showed a statistically significant relationship in all, there were no negative associations, everything was either statistically significantly positive or non-significantly yet positive. So mental health interventions carried social and economic benefits. And I think what I'm trying to say is that the data from South Africa is really supporting this hypothesis, that if we're going to be thinking about links between mental health and poverty in low and middle income countries, we need to be thinking about how to integrate mental health interventions that address depression in a culturally appropriate and sensitive manner, especially for vulnerable populations, and that these can have potential economic impacts. And one last point before I finish off. I know I'm over time, but I just encourage you to have a look at this really interesting article published by Johannes Haushofer and Fair in 2014 called On the Psychology of Poverty, published in Science, which really looks at some of the cognitive mechanisms which I think are evident in our data set. Namely that people living in poverty tend to be more risk averse, tend to discount future opportunities for more immediate rewards. So circumstances of poverty are both causing conditions of depression, the helplessness, the hopelessness, etc. But at the same time, those patterns in themselves do also carry economic consequences. I've got a few limitations which I can talk more about in question time if you want to ask me about those. And I'd just like to thank Murray Leibrandt and colleagues in the NIDS team, and also our funders for Prime and Affirm who've covered my time to do this work. So thank you very much. So I think you said 2 questions? 1 or 2? Yeah.
Wow, Crick, I thought that was absolutely incredible. I got about 6 questions myself, but
Okay.
Who would like to kick off? They're so shy.
Okay. Well, we can wait till the discussion time.
Is there any questions? I'm going to keep them to the... can I go at least ask you one?
Sure.
Okay. Yeah, I think isn't it fascinating that all the interventions that you described in that review seem to have only tested mental health treatments and not integrating poverty alleviation that's always been my kind of wish to do a study like that.
Absolutely.
And your data would just really support that. So what were your next steps?
Well, I mean, this is exactly where I want to go next, is to say, well, can we include, for example, in conditional cash transfer programs, can we include in conditional cash transfer programs a task-sharing mental health component, like a task-sharing, culturally appropriate psychological intervention that might be addressing particular needs, say, of women during pregnancy, which might then have economic spin-offs. And we need to do a kind of factorial design so we can look at both the economic impacts but also the mental health impacts of that kind of combined poverty alleviation and mental health intervention. So I think that's where we should be going next.
Any questions? Yeah, Tunde, you've got a question. I know you have.
Well, I've just been told that most of the systematic review was actually common mental disorders. What informs not going the area of psychosis? And then, wonderful study, I'll say. What are like you said, that the next step is what you want to, you just told us about the next step you want to go into. What are the other likely areas that people that are interested in this area can look into?
Yeah, great, thanks. I think there's a real dearth of representative data on psychosis in low and middle income countries that will allow us to do this kind of analysis over time. I think organizations like Basic Needs have done really interesting, innovative work in combining poverty alleviation, livelihoods programs with targeted mental health programs, especially for severe mental illness. And we've done an evaluation on their Kenya program in rural Kenya, which showed really quite encouraging results. And Victoria Dementia, I don't know if you've come across it, but in Psychological Medicine just a couple of months ago has published a cost effectiveness analysis of that data set, which shows that it seems to be quite cost effective, the whole approach. So I think this is where there's lots of potential for integrating an economic upliftment, livelihoods component to community-based psychosocial rehabilitation programs, for example, in low and middle income countries. Our first systematic review did focus on common mental disorders. We started huge and trying to do everything, but we ended up just focusing on common mental disorders. So that's another area of work. I'm currently working with Valentina on a systematic review on suicide and poverty at the moment. So I think there's room for a systematic review on severe mental illness and poverty, which hasn't been done yet. So there's lots of stuff to be done. Thanks.
One very quick question at the back.
Yeah, just really quick. You reported on, thanks so much. You reported on the severity of depression and how that is, more prevalent to determining poverty. But did you go a bit deeper into your scale and see what were the specific symptoms maybe of depression that were affecting?
Yeah, we haven't done that yet.
Relationship.
But it's a really great idea. It'd be nice
Perhaps
to look at
somatic versus cognitive.
Exactly. Yeah, that's something that we could look at. And especially picking up on this idea from Haushofer and Fair that there are particular cognitive sets, particular negative thinking styles that perhaps trap people in circumstances of poverty. And it'd be nice to try and look at ways of operationalizing those measures and then putting those in a nationally representative data.
Yeah, because it's an incredibly rich data set, and the longitudinal aspect you can really take advantage of it. It's
great.
Really good.
Yeah, thank you. Okay, thanks, Maelenn.
Okay, so our next speaker is Rochelle Burgess. Rochelle is a lecturer in health and social care at London Metropolitan University and also is a research associate with the Health Economics and HIV/AIDS Division of the University of KwaZulu-Natal. Rochelle is a critical community and health psychologist specializing in global public health. We're really pleased to have you here today. Yeah. The slides, is it just...
They're on the desktop.
You're okay. Okay, great.
Okay. Well, it's a pleasure to be here today. Extra exciting for me because I spent many years citing your work, so it feels quite surreal to be the person that talks after you, but perhaps that means I've been paying attention to what you've been saying and trying to see how I can move further. So What I'm going to talk to you about today is basically has ended up being a sort of a summary of my PhD work, which was carried out between 2010 and 2011 in KwaZulu-Natal in South Africa. And what that study was looking at, it was trying to explore community mental health services for women affected by HIV living in extreme poverty. And it used ethnography to try and look at the realities of using sort of a community mental health system, sort of within the primary health care model, to help women tackle some of the issues they were facing. So what were the realities and the limitations that practitioners faced? How did they work with women? How did women understand their own mental health in the context of their wider lives? And so I'll go through some of the background of that, and then end with some recommendations that I think build quite nicely on some of the stuff that's coming out of your new study, Crick, in the sense that trying to think about how formal mental health sectors can start to integrate sort of more socially anchored approaches within mental health programs. So if we think about the fact that women tend to be more affected by conditions like depression globally, a lot of this is linked to the sort of data around social determinants of mental health. So in South Africa, we know that violence and sexual assault is linked to poor mental health outcomes. We know experiences of poverty are also associated with that. And then when the HIV aspect is added to that, we know that there is increased risk for mental health issues linked to context of caregiving, dealing with loss, and also managing stigma in relation to your diagnosis. And when we think about how we try to cope with and grapple with the vast levels of need, particularly in low and middle income countries, the integration of services tends to be what we recommend. We look a lot at the importance of what Thornycroft talks about as a balanced care model, and so looking at the fact that we should be balancing and increasing our ability to recognize and treat people early on in primary healthcare settings, and supporting primary healthcare settings with more specialized centers. And in South Africa, it looks a little bit like this. So this model here is an adaptation of the implementation model from South Africa, the 2003 model. A lot of these features still are prevalent in the new implementation strategy that came out just last year. And when we think about what we mean by community mental health, we're sort of looking at 4 areas that are expanded here. So we know the importance of community outreach. A lot of this might be dissemination programs to try and increase local community knowledge about mental health issues, psychoeducation programs that might be involved in sort of services that are brief intervention services that are delivered within clinics, trying to help people understand how to take their medicine, what their medication is for, recognizing depression as a wider issue, and then the importance of being able to access services that are very close to you in your own sort of local community. And in South Africa, this is embedded within a district health model. And so here, if you look at this diagram, it sort of shows you the levels of care, sort of tiers of care. And so at the community down here, we are thinking about individuals and groups like NGOs, community health workers, traditional healers. These might be primary health care centers or satellite clinics, as they were called in KwaZulu-Natal, where I was doing my work, who are supported by district hospitals, who are then supported by regional hospitals and tertiary hospitals. And so this is the theoretical model that is trying to sort of work. And what I wanted to do was sort of look at what that looks like in everyday practice. So I spent a lot of time at a district hospital in a very rural part of KwaZulu-Natal, sort of about 8 hours north of Durban, on the border of Mozambique. And this community was marked by very high levels of poverty and unemployment. The most recent data at the time of this, the study was 2006 census data. And they found at that time that almost half of the population was dependent on social welfare grants, and that was linked to high levels of unemployment or temporary employment or inactivity among both men and women. The survey also said that 60% of people resided in Western-style housing. And I put this image here to sort of give you a context of what this Western-style housing is. So it is dirt floors in sort of cement walls with corrugated iron roofs. And so the point of my sort of ethnographic approach is to try and put the reality and the face behind a lot of the statistics that we see. And so this, for me, was one of the things that I was most sort of, yeah, Western housing, okay, sure. And so this person who was being interviewed actually, and allowed us to take this photograph, spoke a lot about how difficult it was to live in this house with 11 people, sometimes up to 13 if the sort of nieces and nephews came over and stayed around. And so it's important to think about sort of what some of these wider contexts are that may limit or impact the ability of services to be effective. And so here's a little bit more about the study itself. The method used was a motivated ethnography. This is a social psychological approach to brief ethnography, if anybody is familiar with ethnographic approaches or uses them. And the point really, as I've said already, was to look at the daily reality of services. And so it was over about 5 weeks, and I essentially went to work with the local mental health team at the district hospital every day, sort of observing a lot of their practice, going to clinics, traveling to clinics, talking to community members. And so I'll talk to you today about 2 samples. So the first sample is a group of women who were affected by HIV and who, on a population survey that was completed the year before, had been identified as having symptoms related to depression, anxiety, and PTSD. And so many of them were classified as being either at risk or meeting criteria for one of the common mental disorders. At the time, none of those women were in services. I also did interviews with the local practitioners. I did sort of a cross-section of individuals working within the mental health or the community mental health model. So people at the primary level, so NGOs, moving upwards all the way to the tertiary psychiatrist who was supporting them, just to get an idea of how the model sort of worked over time. And so I will sort of take a whirlwind tour of the 3 or 4 papers that have come out of this study. So if you're interested in knowing more, all these papers are published and you can go and look at them in a bit more depth. But we'll start off by looking at women. And what I wanted to do in those women's interviews was give women an opportunity to talk about their lived experiences that were behind their survey. So they were asked questions like, you completed the survey and it asked you about times when you felt depressed, couldn't sleep, anxious, or worried. Could you talk about sort of the things that happened in your life at those times? And across the sample, we found that there were 4 primary categories that women described as driving their mental distress. And, a lot of it is on that social causation pathway. We're looking at things like food insecurity, the inability to feed their children was a big issue. Being experiencing crime or being the targets of vigilante justice was a big issue among many women. A lot of women struggled with being in polygamous relationships that often resulted in abandonment by partners. And of course then issues in relation to caregiving or being HIV positive was a factor for some women, but not all. And what was kind of interesting is that even in HIV positive women, HIV/AIDS wasn't the foreground. It sort of took a back seat to the regular sort of survival issues that manifested in those other areas. And these little boxes here about norms are trying to highlight some of the background to how women made sense of this. So distress in relation to problematic relationships was actually due to the fact that there were sort of roles or norms about how women should behave in relationships. And so if a woman was abandoned and she was talking about how this made her very sad and he married somebody else and this was making her sad, and she was sort of asked, well, how do you cope with that? What do you do? And she this sort of a norm in that community, which was primarily Zulu, was around women who were strong and stay committed to their families despite whatever happens around them. And so they say, well, my job is to stay here and wait, and so I stay here and wait. And so that relationship between that norm and their everyday experience sort of fed into feelings of sort of hopelessness and isolation that drove their distress. And another thing that came out of the interviews with women was the things that they were already doing to try and cope with these situations. So a lot of women spoke about becoming involved with income-generating activities, trying to do anything they could sort of make ends meet. Some women talked about mobilizing peer support, so using local relationships with those around them to gain access to resources in a time of emergency. Some women would talk about going to see traditional healers or in going to see people at the hospital in times when they weren't quite sure what to do. And most all women sort of used some form of psychological framing as a way of trying to cope with the things that they couldn't tackle. And in this instance, they were able to sort of reframe something as beyond their reach, so that they would leave up to God. This is something God will take care of as opposed to me, so then their faith sort of helped them to cope with that. Or, as again, in relation to those norms that I mentioned. A sort of caveat here was that most women found that there were limits to each of these types of coping strategies. So, for example, if you were going to mobilize peer support and you were asking people for some extra food or to borrow some money, there was ultimately only a limited amount of time that you could do that. And there were sort of accounts of women who then experienced vigilante justice, so sort of cruelty at the hands of community members when their sort of ability to ask for help had run out. So moving to the practitioner side and trying to get a sense of what happens when women then move from the community into the formal service sector, we started off trying to understand how practitioners made sense of the women they engaged with. So how would they explain or say that women would make sense of their distress, and did they sort of agree with that? And so the framework that practitioners used was almost identical to the framework that women were using. So there wasn't sort of this sort of division between the two life worlds, as you might find. So one of the critiques in a lot of psychiatric or mental health literature is that there is a disconnect between people who use social models to talk about their distress and practitioners who use biomedical models to talk about their patient's distress. And this wasn't here. You had practitioners who were very aware of the realities that women faced, what they were struggling with, what was the cause of their distress. And what it came down to was they were sort of trapped in a system that made it a little bit difficult for them to help women in the ways that they knew women needed help. And so this is sort of where I come back to some of the research that you're wanting to do, Crick, and sort of thinking about expanding what the services on offer in the formal health service allow. So this is the model that was developed to explain how women sort of move through services in this community. Because there was very little community outreach or community knowledge about mental health and awareness, women entered services usually at points of crisis because they either had attempted suicide or had a sort of a nervous breakdown that looked a little bit like a schizophrenic episode. So then they would go into the district hospital, somebody would take them in, and once they were in there, there's the policy is that the district hospital will keep you for a 72-hour observation period before moving you on either to the community or discharging you to a regional center where they have inpatient beds. Typically, it was difficult to actually get people to move to the regional hospital. The transport was unreliable, and it was about 5 hours drive. So most times people ended up being either getting permission to stay a little bit longer at the district hospital, but usually were discharged back to the community. So within sort of mirroring policy guidelines, individuals are typically seen by multidisciplinary teams. And the multidisciplinary team was made up of a mental health nurse, a physiotherapist, occupational therapist, and a social worker. The hospital, at the heart of the study, only had 11 doctors on staff, so a doctor wasn't able to be present at many of these meetings. They often signed off on diagnoses a lot later. And so the group would usually give one of two diagnoses to women who came in with that sort of life context. They would either say that you have experienced a psychosocial psychotic episode as a way of trying to maintain the importance of this, or that they were experiencing depression linked to psychosocial causes. Any sort of biomedical or pharmaceutical intervention was always paired with some sort of social response in an effort to try and respond to what women were saying. So that might have included being referred to a support group in the community, being referred to a social work to have an opportunity to access a grant or emergency food parcels, being sent to the NGO to get some support at home if you were alone and isolated, and being told to follow up with your primary care nurse. In number 4, when we try to look at the home environment, these blue boxes highlight the barriers to each of these programs. So what happened was, because of lack of funding, support groups were canceled and non-existent, never knew when it was going to come back or happen again. In terms of social work, because there was a lot of stigma at the social welfare department, a social worker had to go with them in order for them to be seen, but there were 2 social workers in the entire hospital, so they couldn't go. In terms of relying on the NGO or the primary health care nurse, there was a lot of stigma within both of those groups around mental health, not really wanting to see people who had a mental health diagnosis. There was sort of a local narrative that during the summer, a certain tree was in bloom, and when that tree was in bloom, people were more likely to be more psychotic, so I don't go see anybody in the summer. So I will go see them in the winter, or not at all. So all of these sort of attempts to try and respond to the social drivers and at the heart of women's distress didn't quite move through. And so one of the things I sort of started thinking about at the end of that was trying to look at different ways to think about how we do community mental health. And one thing that I kept coming back to was the importance of thinking of communities in supportive environments as quite important. And so that would lead to sort of a framework of community competencies. And this is the work of my supervisor, Catherine Campbell, who did this work primarily in the field of HIV and AIDS. And it's a broader way to think about how we engage with communities and what sort of resources intervention should be seeking to provide. And so here we see knowledge and skills, safe social spaces, the importance of solidarity, and partnerships that provide access to resources that are a little bit more long-term and sustainable than relying on peers who are in the same sort of conditions and environments as you. And so going back to the data coming out of my study, the argument was trying to look at how the coping skills of women that were indigenous to women might map across some of these competencies. So are there sort of skills that programs could seek to develop in trying to create opportunities for women to focus on more than just the biomedical aspects of their distress once they're sent to services. And so critical thinking was identified as important to try to create opportunities for women to get out of these negative cycles of psychological framing. The importance of agency and solidarity, so knowing that you can collectively rely on others in your community, but beyond that, thinking about the importance of partnerships outside of that, so that you aren't just relying on your inner circle where the distress is and where you're all sort of in the same situation, but there's an opportunity to gain access to additional resources that you might not have. And so this is sort of a model of trying to think about what this might look like if it were embedded within a primary healthcare model. Sort of thinking about task-shifting ideas, what is already present. There's a role of mental health counselors in the sort of primary mental health care model already. And the idea is that this particular individual could be capacitated to do and promote sort of women's local development around wider issues. So their role is to sort of enable access to more important partnerships, to sort of be a bridge between this sort of space where it might be a health intervention, but also being that bridge to creating opportunities for either things like income generation programs or whatever sort of women in these groups would locally identify as valuable. And I think the importance of having something like this embedded within the primary healthcare model is that we know right now that a lot of third sector groups and NGOs do a lot of this work. Crick has already mentioned basic needs, but I think it becomes really important for governments to have ownership and responsibility over these things so they can be more long-term and sustained. So we can move away from having resources that dry up because funding changes, funding priorities change, or somebody who is driving an NGO decides that they're interested in a new topic and then an NGO shifts direction. We sort of see that happening as AIDS-related NGOs now start to lose their funding and they're having to restructure and rethink about ways to remain relevant. So I think it's really important to think about ways to do that. And there's a model of social prescribing which some people here might be familiar with. It is out of Scotland, and what that model allows is for mental health practitioners to give prescriptions of sort of community interventions as part of your treatment. So you can go to an art class, you can go to a writing group, you can go to therapy, or you can go to the gym and get a gym membership. And so it's these types of thinking around what counts as your treatment if it can be made within the context of people's lived environment. So that's it from me. Just a quick acknowledgement of some of the collaborators on this study, including some of my funders, and the LSE where I did the PhD. Thank you very much.
Very much, Rochelle. Very inspirational talk. Thank you. Do we have some questions for Rochelle? Yes, please.
From your point of view and from the privilege of being able to be there and to do ethnographic work, which is sometimes the thing that is not in most of the epidemiological studies. What is your opinion about the causation cycle between poverty and mental health? How do you approach that? Because I didn't saw it directly in your presentation.
It's sort of an interesting question. So you're asking about my personal opinion or what's out of the study? My personal opinion.
Personal.
Okay. Well, I think that my personal opinion about that always comes back to the person whose narrative I am listening to. I think it is dangerous to try and say it is one or the other, and perhaps quite similar to your earlier comment, Crick, in the sense that what do we miss out when we say it's nothing to do with social drift, or it's only to do with social causation. I think in the community where I worked and in the groups that I tend to work with, particularly women who are marginalized in many different ways, you see a very strong argument for social causation. And in the fact that if interventions aren't made to be relevant to the social causation aspect, people just sort of keep going back to worlds that are fragmented and complicated and struggling that can then continue to sort of put people at risk for experiencing mental health problems. So for me, I think that in the communities where I work and in the groups that I work with, it's very much about causation, but that social causation, but that doesn't mean that social drift is not something that contributes to the experiences of others. So for me, I stick with the people that I work with to allow them to define what the causation is, which feels maybe like a cop-out, I don't know. And right, how they have attributed to lots of these social factors and of course contexts that they're living in. And of course, I mean, I think it's really interesting and useful strategy in terms of this social engagement. So I guess, right, in terms of the pathway that people are taking in terms of getting into services and, when things are really acute in this crisis point. Do you have some thoughts about how to build social resources up maybe earlier or engage people? Well, I think that is sort of if I can just quickly go back to this. The thing about community competencies, and so I didn't really have time to explain what they were, but that type of intervention really tries to equip people with the psychological and the sort of social relational resources to develop partnerships and relationships that enable them to engage with some of these issues. So it's trying to make communities themselves as a whole more resilient or more engaged with the wider systemic issues that are driving their distress. So one way to go about it is inserting sort of some of this stuff into mental health programs, and that will get people to go this way. But also, if you're doing general community strengthening, then you sort of avoid this crisis point because communities become more resilient as a whole. I think the best thing for you to do would be to do a little bit of reading. So Catherine Campbell has published about 8 or 9 or 10 or 1,500 articles about community competencies for HIV and AIDS. I've just sort of put a book chapter out about it for mental health. So if you'd like to see me after, I can just sort of give you some of those resources that talk about what that looks like.
Very quick one.
I just have a question about the role of spiritual healers.
Yeah.
Because obviously you said that they're part of the community and they are consulted before the point of crisis. So I wanted to know if there's, I don't know, in your findings of research, if there was any kind of education for them that they could help women before that stage.
I did talk to traditional healers as part of the ethnography. There are about 6 of them that sort of work within the community that I engaged with them. So they had not received any formal mental health training. They had received HIV training, but not mental health training. And because of their experiences with their HIV training, they sort of had a bit of reluctancy to engage with the formal health sector. They sort of felt like ideas were being poached, they weren't being respected, that they were being told to participate in a system in one direction, which is sort of feeding people up and feeding people in, but their work wasn't very valued. So they sort of gave this idea that they weren't involved, they'd like to be involved, but they were nervous about being involved. And I think that there's some interesting work on sort of traditional healers in South Africa that's actually been published. She's in Cape Town. Catherine, yeah. So Catherine Sorsdale has published quite a few papers sort of looking at sort of how traditional healers think about their participation within mental health, how they're being used or sort of not being used. But there are sort of interest in trying to get them involved. The national strategy talks about the importance of them being involved, but I do think it will be something that is tenuous a little and complicated to do. But I'm interested to sort of see how it comes out because they are a very important resource, and it's a sensitive issue because traditional healing practices can be, some of them have dangerous after effects, but not all of their practices do, and it's about sort of finding the best way for them to be actively involved in sort of the community mental health model. I don't know if does that answer your question? Sort of. We can talk after. I'm going to be around. I'm cognizant of the time.
Yeah. Thank you
Okay,
so much.
thanks.
Yeah, thank you. Okay, so our next speaker is Maelenn Guerchet, who's postdoc researcher in the Global Observatory for Ageing here at King's College London, and also works on the 1066 Dementia Research Group. And among her many of her work, Maelenn's been working on estimating prevalence of dementia in 3 francophone-speaking African countries. So, welcome, Maelenn.
So my talk today is going to be presenting one of the, or few of the first results from the last 1066 study, the in-depth study, which is examining the economic and social effects of care dependence in later life. So just a bit of background. Disorders of the brain and the mind are leading contributors to disability and dependence, so need for care. Dementia being the first one. Those results are actually coming from the previous 1066 studies, with 36% of the dependence attributable to dementia and 25% of the disability attributable to dementia as well, which is more than limb paralysis or weakness or stroke or depression or other health condition or impairments. What we know about care arrangements for people with dementia is that for them it's unusual to live alone or with a spouse only. Most of them are living with children or children-in-law in their household. In the household, in 1/3 to a half of the household, there's children under 16 years old living with the people with dementia. And most of the time, the main carer of the people with dementia are the spouse or a child. So caring for people with dementia in low and middle income country represents 3 to 4 hours of personal activities of daily living care per day, up to 8 hours for people with severe dementia. And we know that in low and middle income country, as in high income country, caregiver strain is really high. Of course, there's an economic impact of caring for people with dementia, with some of the people have to give up paid work to care or have to employ paid caregiver to care for their family. In most of those countries, social protection is fragile, and we know that there is limited help seeking, but caregivers crave for more information, advice, and support when they have people with dementia in their households. So the key questions about in this in-depth study was around dependence, encouragement, and vulnerability in age life, with those 5 main questions. Is the onset of dependence associated with household encouragement and economic vulnerability? What are the pathways? What factors make household resilient? Does this depend on external policy environment, including the reach of social protection and health services? And what factor influence the allocation of care burden inside and outside the household? So the in-depth study has been carried out in 4 countries, 2 Latin American countries, Mexico and Peru, China in Asia, and 1 African country in Nigeria. For today, I'm just going to present the results from Latin America and China. We don't have all the data yet from Nigeria. And for those 3 countries, we've got data from both urban and rural areas. The in-depth study is a mixed method study. So for the quantitative part, we've got a nested incidence case control study. And for the qualitative part, we've got household case studies. Again, today I'm going to focus on the quantitative part of the first results we've got. So we've got 4 groups of interest in-depth, defined according to the previous 1066 studies, baseline and follow-up. The first group is chronic dependence households. That's the households where we have at least one older person who was dependent at both baseline and follow-up. For the incidence dependent household, the people with were dependent at follow-up but were not dependent when we were here at baseline. We've got control households where there's no people with dependence in the household. And we also have the care-assist households, which are those where there was someone with dependence and needing care at baseline, but who unfortunately died before the follow-up. So regarding quantitative methods, we've got two different sides of it. We've got a full economic evaluation looking at household assets, assets in savings or investments, household income, consumption, including food consumption, out-of-pocket expenditure, and many other things like debt, loans, financial strain, and a subjective assessment of financial status. And we also have household composition and roles with the current composition of the household and the changing since the baseline interview, the current economic activity of all the household members, and the health status of all household residents and their needs for care. Among the economic indicators, we've got mainly the income coming from external sources, which are any gifts or donations coming from outside the household, friends, family, charities, or NGOs. We looked at the catastrophic healthcare spending, which is when more than 10% of the total income of the household is spent to cover healthcare costs. And we looked at economic strain over 3 years as well, which was defined when they had to ask for help, any friend, relative, or any other institution, when they had to borrow from a bank, draw on savings, sell stocks or shares, cut down on food consumption, try to find an extra work, or apply for grants, food parcels, or food vouchers. So to start with the results, just a few characteristics of the selected households and their older residents. When we look at both all the three groups, control, incident, and chronic care households, we can see that the more the needing care, either incident or chronic care, and the more the prevalence of stroke is high. It's the same for the three countries. When we look at dementia prevalence, it's even higher in those households with incident or chronic care, and we can see that the prevalence of dementia in those incident or chronic care households is actually higher than the one for stroke. When we look at the care in those households, we can see that dementia, either alone or in combination with other conditions, characterize dependence, and particularly chronic dependence with quite high percentage in those households. About carer characteristics, if we compare male carers and female carers, we've got most of the carers are women. If we look at the characteristics, they're broadly similar, but we can see that male carers are more likely to be employed, while female carers are more likely to be homemakers. There's more psychological mobilities and strain in female carers as well. And there's a high proportion of carers who had to give up on work to care, and also 2/3 of the carers had have children aged under 60 years old, which means that they have to care for both children and old people. Dual responsibility to care. So the initial findings are lots of numbers. If we look at the income and expenditure in those households, it's pretty similar for Peru and Mexico, with higher incomes total or coming from external sources, and expenditure in urban areas than rural areas. It's not the same pattern for China, but this probably comes from the fact that in China, where we did the study, the catchment area we used, it's quite close to the new Beijing airport, so people are actually selling their lamps and are receiving incomes quite a lot over the last years from that. So that could be an explanation for the different pattern. If we look at the prevalence of economic strain indicators, we can see that economic strain is higher in both the Latin American catchment areas than it is in China. The catastrophic healthcare spending is between 10 and 30% over all the sites, and we can see that less residents are giving up work in Mexico, both urban and rural, and in urban China. So the main result of this study, which is about the impact of living with a care-dependent older person, you can see that in chronic care households, we observe a reduced expenditure and food consumption significantly, while in care exit household we observe a decrease in incomes coming from external sources, and also a decrease in healthcare spending and catastrophic healthcare spending, while the people with needs for care has died. So the summary of all this is that we found some evidence of economic impact of caring for older people with a reduced expenditure and food consumption in chronic care households, and a trend towards increasing economic strain in all care household groups, but which was statistically significant only when we merged all the data. However, regardless of needs for care, we can see that households with older residents often benefit from income coming from external sources. The healthcare spending is also quite high, and both income from external sources and healthcare spending are much lower in care exit households after the death of the older residents who needed care. And we also found that catastrophic healthcare spending may be more common in incident care households. I haven't put those slides in the presentation, but we did have a look at the effect of having someone who needs care because of dementia, and we didn't find a major difference when we focus on people with dementia, meaning that it's probably not the condition which is important in all this, but the fact that they need care and they need attention. And that's it for me.
Maelenn, thank you particularly for keeping to time. That was incredible. Okay. Does anyone have any individual questions for Maelenn? What I'm thinking is, as we've only really got 5 minutes left, would it be a good time to bring the whole panel up 5 minutes and try to come to some overall points? That would be great. Kick off. I mean, either any of you or the audience. Yeah, someone.
Thank you. I have a question for all of you. It's about implementation, like how do you want to use your data? And I was thinking, those presentations were great and the results were brilliant. The only thing is that if they just stay as results in papers, it's not going to be very useful as such. And unfortunately. So, and I was thinking, how do you want to move it forward and make it concrete and make it useful for a policymaker? And for example, when I was seeing the picture that Crick used in one of his articles about the linking between poverty and mental health and the different interventions that may be useful and may have an impact. One thing is that it's quite useful and it's quite frequent to have some poverty measure taken when you do an evaluation of a mental health intervention. But it's quite more difficult to have the opposite one, so for some poverty intervention to have some mental health indicator taken. So there might be some opportunity and so possibility out there, but because mental health is quite complicated and is quite multi-dimensional, it may be difficult for either policymaker or funders or international organizations to promote them, to measure it, and to make some intervention more useful for mental health. So what I would like to have your thought about it.
Okay, thanks. It's a great question, and I think we should be thinking more about what are the policy implications for the findings. I think from our work, I think some of our recommendations, especially to development policymakers, is that they need to be thinking more about mental health as an integral part of development policy and social and economic development policy. That throwing money at problems or providing cash transfers without thinking about how do people actually utilize those resources and what are the kind of mental health interventions that could enable them to make better use of those resources is really a waste of those resources or doesn't achieve the full impact that it could. I think we don't know enough about, as you said, the mental health consequences of poverty alleviation interventions. And I think brief measures like the CESD-10 or brief psychological distress measures, although they don't generate a diagnosis and they can gloss over a whole lot of other issues, are important indicators of some kind of mental health consequences of poverty alleviation interventions. So that's the one side. I think certainly from the perspective of people who are delivering community-based mental health interventions, a lot of the outcomes tend to focus on symptomatology and functioning. And I think we could do a lot more in way of adding, well, what are the economic consequences, both at individual and household level, of some of our community mental health interventions. And I think that's what I really liked about Rochelle's presentation, because I think it was touching on a lot of that potential for building community competency and measuring some of those social and economic impacts. So thanks.
Thank you. Yeah, I agree that it's a really important issue to think about the after of when something is published and how to get things used. And for me, I'm sort of interested, I guess, in the next stages of thinking about how we adapt some of our mental health interventions to be more locally relevant, and so to be more resonant with the experiences of these social determinants. And so one aspect of that, I guess, involves trying to get pilots of sort of these adapted interventions going to see what they look like in practice if they work. I think Basic Needs as an NGO has sort of, we see a lot of success in the combining of livelihoods approaches with mental health interventions, and I think the next step is to see whether that works within formal systems. So I've sort of been looking at and developing a study that tries to pilot what happens if you take sort of brief mental health interventions and put community development stuff within them. So like 2 of your 8 weeks is thinking about community development. And what does that look like? Is it feasible? Is the health sector a place that can contain it? And so hopefully there'll be some good findings out of that, and then we can see where that goes.
So just regarding this study and the 1066 study more in general, for this one we have strong links with HelpAge and the WHO and all the PIs in the countries are really involved with all the authorities. So I'm sure it's not going to stay just a publication, but the results are going to be more disseminated than that. And with those strong links, we also start to work on, for the next stage, and one pilot has been done already in India, an intervention among frail older people, because it's not only about depression or dementia, it's more the whole state of the people at old age, which have an impact or can have an impact on their household. So there's been an intervention piloted in India, and during the next 1066 study over the next years, a third wave, there's going to be an RCT to test this intervention in more different countries on frail dependent older people. And I think it's also one of the topics of a new grant we applied for. So, and on the top of this, we also included more questions and items from the in-depth study for the next wave. So we're going to have even more data to try to figure out if this is really seen at the population level, and then apply the intervention to see what's going on. Hopefully, this is going to work.
Hello. You used both qualitative and quantitative approach to define multidimensional concept of poverty, and I was wondering if you think that your research could help to better define which dimensions of poverty are more related to the mental health problems, like is it more the lack of water or the lack of monetary resources, or some. So if there are specific dimensions that you think that are better or more related to, to mental health issues.
Yeah, because it might leave my brain. I think for me, what sort of looking across the three studies shows is that it might not be a particular dimension or feature of poverty, but actually what poverty creates, which is a general sense of insecurity and fragility in people's lives, so the inability to know what's coming next or plan for what's coming next. So in my study, for example, when you had women who food insecurity was a big thing, but it was also about the fact that they couldn't predict what was going to happen in terms of taking care of their children and sort of the knock-on effects of that. And so that is tied to the inability to pay for food, but it's also tied to informal or non-existent employment. And so I think in trying to say that one dimension might be more important as a contributing factor than another, we might be missing out on actually the true complexity of the poverty issue. And maybe a better way is to say, well, what is it that poverty creates? Maybe it's this instability, and I'm welcome for people to disagree with me, but that's sort of my thinking on it.
Okay, yeah, I mean, it's a really important question. In that systematic review that I mentioned on poverty and common mental disorders in social science and medicine that we published in 2010, we looked at a whole range of different poverty dimensions and their associations with common mental disorders. And we found that sometimes in the bivariate analysis, when there were a whole lot of upstream independent variables thrown into looking at the association between those and the outcome, say depression, that a whole lot of them emerged. But as soon as you did a multivariate analysis and controlled for some of those variables, things like income tended to drop away. And what remained more strongly predictive were things like education, employment, housing, food insecurity, so this issue of security. But again, it's very selective. Lots of gaps in that literature, so there's a lot more. I'm really interested in this whole notion of assets and what they represent symbolically to people. as a form of security to help them get through crises, whether it's a health crisis or an incident of violence or a rape or whatever it is. How do resources enable people to rally themselves as a household, as a family, as an individual, to overcome those crises? So that's where I think there could be lots more explored. But it's a really important question. And the whole question of how we measure poverty, of course, is highly controversial. And there's the old classic World Bank, less than $1.25 a day. There's relative poverty measures. There are multi-dimensional poverty constructs now which are used. So I think when we look at this, we really need to look at all of these different approaches, and they all tap different dimensions, I think, of mental health.
So I guess in the in-depth study we've got a lot of different detailed categories for assets, incomes, and a lot of possible explanations or different kind of parts where the poverty could come from, but we're at the really beginning for now, so we haven't been able to analyze this yet. We've got the qualitative part of the study also, which is going to give us, and has already started to give us really nice ideas about how the family cope with all this journey of care and all the events which can lead to someone giving up on work, how the whole household reorganizes himself or itself around different events, around care for the older people. So I think we're going to learn from the qualitative things as well in studies to have another look at what the quantitative data is showing as well on the same side.
Right, I'm very cautious of aware of time now, and I think we'll probably have to carry on discussions over tea. I think it's going to be an almost impossible job to try and sum up the amazing opportunity we've had today to hear your talk. I think I'm really delighted that Maelenn really highlighted the issue of dementia, which is a very neglected area in this whole topic of poverty and mental health. And I think I suppose I particularly took away from those huge percentages that you showed in terms of the impact, the way this disease is impacting on people's life and livelihoods. I think we've heard just an amazing cutting-edge presentation from Crick on, for me, the excitement there, I'm afraid, is the social drift, because my mind's in HIV. I think if you're going to convince a policymaker, to me, I think they know the social causation, they live with it every day, but the fact that you're showing that mental health is impacting in that direction, to me, that's very exciting, and you should be going home writing a policy brief, I think, from this talk we've had today. And I think, Rochelle, you've given us sort of amazingly rich insights into, pointers for community responses to this, as you said, to the quantitative data, and really thank you for that. And I made a few really small things I've taken from that as well, which is very concrete things, which is, what implications does this have for people in mental health services? What should be their makeup? We have, I'm afraid, I work in the IAP service in the UK, and we have a lot of young, female, white, middle class, therapists. And you're talking, the reality of the clients' lives that you've described for us today is, should we not have the genuinely diverse workforce, at least as a starter? But thank you very much, everybody, for coming and for your questions, and particularly